Dr. Panesar, Dr. Panesar completed his medical education, medical school training at Baylor College of Medicine. Liked it so much that he stayed on there for both his residency and his pediatric pulmonary fellowship. Since then, Dr. Panesar has been here in Phoenix mostly, owned his own practice for a while, Crazy About Kids Pulmonary Services out in the East Valley, and has been was on and off with us at DMG during that period of time, but then has come on board with us primarily starting in 2019 and is now our primary pediatric pulmonary attending, both for inpatient and clinic. Today, he's going to be talking about the asthma guidelines that came out. I'd like to say recent. They're not so recent, but most of us probably still haven't read them. So Kelvin's going to do us the solid of going through them for us. So please join me in welcoming Dr. Kelvin Panesar.
Hi, thanks for having me. So we're going to go over asthma guidelines. We're going to kind of touch on some basics and some pathophysiology of asthma so we can get a good understanding of why the guidelines are there and how to use them for our benefit. So childhood asthma, we're going to talk about definition of childhood asthma, prevalence, impact of childhood asthma, not only on the patient itself, but on the family as well, because if you look at it more than, depending on area where you live and where you practice, a lot of times 10% plus of all hospital admissions are related to asthma. And so there is a heavy medical and cost burden with these patients. And it does take a toll on their families because, as you know, asthma is a chronic disease. So there's a few things with childhood asthma that could be different from adults. We still have common symptoms: coughing, wheezing, dyspnea at rest and exertion, chest tightness. Children with asthma tend to cough more than they wheeze. Adults with asthma tend to wheeze a little bit more than they cough. But common triggers, especially in kids: viruses, weather changes, pollution, respiratory irritants. That could be strong things with strong odors: bleach, perfumes, colognes, all those things. Ozone's a big one here in the summer in Arizona. So you might not be able to detect it, but it can be a huge irritant. So what is the definition of asthma? So the key function or the key definition of asthma is that it's a reversible small airways obstruction. Most other diseases that involve small airway obstruction are actually non-reversible. That could be COPD. It could be chronic lung damage from chemical smoke inhalation, etc. So you can have variable symptoms of wheezing, shortness of breath, chest tightness, cough, and another hallmark of asthma is that these symptoms and airflow limitations quite variable. And one day you could be doing well and not have much in the way of symptoms. The next day, if you have the wrong exposures or viral exposures, cold, hot air, overly hot, dry air, that can trigger things off. But the airflow obstruction is reversible. And remember, in asthma, there's airway hyperresponsiveness, and it's due to stimuli. The chronic, the hallmark that we look at is which causes symptomatology, flare-ups, etc., is chronic inflammation. We'll touch on that. All right, so there's different phenotypes of asthma. Allergic asthma is the most common phenotype that we deal with in the outpatient world and in the inpatient world. Non-allergic asthma tends to occur later on in life, but we do see this in kids as well. And these folks do not respond as well to inhaled corticosteroids. When you have late onset asthma, that's usually asthma that occurs in adults. The adults that start having onset of asthma tend to be less allergic, but not always so. But usually they'll need higher doses of inhaled corticosteroids to get responses that you need. Then we run into the subtype where you have asthma patients that have persistent airflow limitation that don't reverse on pulmonary function testing. And usually these patients will have long-term symptomatology. There's heavy airway remodeling in these patients. And then we have the obese folks with asthma. And when you look at their, if you were to get like sputum eosinophils, they're low as opposed to our allergic asthmatics who have higher sputum eosinophil counts. Well, why do we look at guidelines? Asthma, as you know, is a common disease, lots of comorbidity, lots of cost to the patients, missed work for the parents, missed school time for the patients, and a lot of times our patients will need chronic medications as well as acute rescue medications. And, if they need admissions to the emergency room or the hospitalization, that could be a very costly burden as well. So we have guidelines to kind of help streamline the care that's involved in our children and even adults, obviously. But you want to ensure consistent care that's evidence-based, and this will improve your outcomes and hopefully quality of life for your patients who have asthma. So I'm going to go over two of the major guidelines. There's the NIH, or National Asthma Education, or National Asthma guidelines that are more American, and then we'll go to the international or GINA guidelines, and we'll talk about similarities, differences, and we'll kind of run through a few things with that as well. So when you look at the NAEPP guidelines, some of the key features with this is there's a lot of emphasis on assessment and monitoring of these patients. There's also quite a bit on patient education. Patient education is stressed, and we always push for our respiratory therapists and nurses to become certified asthma educators as well. I'm a certified asthma educator as well. I've sat on the asthma education exam board for several years as well. And it's just good overall to be able to teach your patients and their family how to monitor and control their asthma. I think the better the patient education, the better that these patients do in the long run. There is emphasis on control of environmental factors that can affect asthma, animal dander, smoke exposure, dust mites, outdoor exposures as well. And when it comes to asthma control and care using the NAEPP guidelines, there is a stepwise approach to control of asthma. We'll go over that here in a minute. So obviously, asthma is a chronic disease. And even though you're not symptomatic, there's still chronic inflammation in the airways. There's still always some activity going on for which you have to really pay attention to. And then during, viral exposures, cold exposures, irritant exposures, you can have flare-ups of your asthma symptoms, and that's when you'll need to enact, a rescue therapy or go to your yellow or red zone plan on your asthma action plan. So with the EPR3 guidelines, this is the stepwise control. This is a little older of a slide, so biologics are not included, at least in this one. But usually if you're, and we'll talk about biologics in the future a little later on, but usually if you're going to do biologics, I tend to enact those step 5 or step 6. But again, if the patient's having some recurrent flare-ups that are more difficult to control, or there's some rapid progression, and you're having to step up quickly, I might enact a biologic even at the step 4 level. So with the EPR3 guidelines, there's intermittent asthma and persistent asthma. For intermittent asthma, which will obviously be mild asthma for a vast majority of your patients, then a quick-acting bronchodilator is usually needed on a PRN basis. Again, they're not having severe or chronic enough symptoms to warrant starting a daily for starting a daily controller medication. Sometimes when I make rounds on my IC patients that are admitted for asthma, a lot of times they're diagnosed with mild intermittent asthma. But remember, if you're admitted to the ICU for an asthma exacerbation, you're classified kind of as your most severest symptom. So that puts most of these kids who are admitted to the intensive care unit as severe asthma, because that kind of puts you in the life-threatening category, especially if you need to go on non-invasive or even invasive positive pressure ventilation. So when you have more persistent asthma, that's when we start enacting controller therapy. And for our step 2, we do low dose inhaled corticosteroids. Now, again, this is an older slide, but back in the old days where we did use cromolyn, the Docramil, Tylate, and theophylline, those were fun times because during asthma exacerbations and some hypermetabolic states such as fever, with viral infections, your body just chewed through theophylline and your levels would drop, and therefore you aren't protected. So we really try to hone in on low dose corticosteroids, and then those patients who respond to leukotriene receptor antagonists tend to respond fairly well if they do respond. And then when you look at step 3 and step 4, you're increasing the amount of controller therapy that you use. Usually you'll add on a second agent, such as a long-acting bronchodilator, and that could be in the form of like your Advair, your fluticasone and salmeterol or Ceravent, or you can use one of your other combinations such as Dulera, which is mometasone and formoterol, or Symbicort, which is budesonide and formoterol. And usually in the step 3 and 4, we can also institute what's called smart therapy. And that's kind of a newer therapy, and it was kind of introduced to us from the European literature, and we'll go over this as well because it can be a nice alternative for some of your patients as well. But remember, the key thing about the NAEPP guidelines is you're always assessing control of asthma symptoms with your asthma patients, and that could be your asthma control testing. You're looking at symptoms. I like to look at pulmonary function testing as well. If you have the ability to do exhaled nitric oxide, that can also be quite a useful tool for your allergic asthmatic patients as well. So in the NAP guidelines for children, just to kind of give you a little rough overview from the previous slide, for our youngsters that are less than 4 years of age who have intermittent wheezing, usually we will do, sometimes recommendations are to do a short-acting bronchodilator as needed, but for those who have some more severe symptoms or a little bit more persistent of symptoms, not enough to qualify them for step 2, sometimes we'll do add-on inhaled corticosteroids to be used during exacerbations. If they're greater than 4 years of age with mild persistent asthma, usually we'll use a low-dose inhaled corticosteroid with a PRN dosing of your quick-acting bronchodilator. If they have moderate to severe asthma, then usually we will increase our inhaled corticosteroid dosing or even consider adding smart therapy. If they're greater than 12 years of age with mild asthma, we'll kind of treat them as if they're persistent, obviously, and we'll do a low to moderate dose of inhaled corticosteroid or our PRN dosing inhaled corticosteroid with a short-acting bronchodilator. If they do have moderate to severe symptoms, then we'll switch to more of a chronic therapy, and that includes your dual therapy, your inhaled corticosteroid with long-acting bronchodilator, or instituting smart therapy. So what is smart therapy? So it's a single maintenance and reliever therapy. And usually for the NAEPP guidelines, we usually can introduce this or give this as an option for our step 3 and step 4 therapy. it's targeted for patients who have poor control that are on maintenance inhaled corticosteroids and long-acting bronchodilators, and they do require more rescue dosing with their short-acting bronchodilator. Usually, the main medications that we use for smart therapy is your inhaled corticosteroid plus formoterol. Formoterol is a long-acting bronchodilator, but it's quick acting, and you can administer it either as a PRN or as a maintenance therapy at 1 to 2 inhalations, 1 to 2 times per day, and then you add on 1 to 2 puffs as needed for increased asthma symptoms if they're having more asthma symptoms. The maximum number of puffs per day will be, it usually is considered 8 puffs per day, which gives you right up to 54 micrograms per day your formoterol. Beyond that, there might not be as much um, benefit with using your long-acting bronchodilator. Um, Key thing is do not use Ceraventol or salmeterol. That's your component in your Advair or your fluticasone with salmeterol. It has a long ramp-up time, and you don't get quick relief from using salmeterol. So that's kind of not that's actually not used for your smart therapy, because you want to have that combination of inhaled corticosteroid plus a short acting or long acting bronchodilator with a very short onset time. With the recent inclusion of brand name Air Supra, which is actually budesonide with albuterol, which is your short-acting bronchodilator, that can also be used for smart therapy as well. The Europeans do have a little bit more longer-term data using this technique, and it does appear that there's reduction in both the asthma exacerbations and the use of systemic corticosteroid or need for systemic corticosteroids by using smart therapy, because you're kind of limiting, or you can reduce your dosage of at least systemic corticosteroids and perhaps even inhaled corticosteroids. There may be some lower growth suppression when you institute smart therapy. The big caveat here is the insurance plans aren't quite on board with that. Even if you look at the FDA recommendations, those aren't part of the FDA recommendations here in the United States. So oftentimes, if you need a 1 month supply of, say, your budesonide formoterol or mometasone and formoterol to provide the maintenance therapy plus the rescue breaths, one inhaler per month might not cover what's needed. So oftentimes you have to get pre-authorization from your insurance companies, which can be a pain in the neck, especially depending on who you get on the phone and who you're trying to have them understand what smart therapy is, even though there could be a good benefit from instituting smart therapy. A lot of times your insurance companies might not see things eye to eye with you on that. So who are candidates for smart therapy? Patients who require maintenance therapy for steps 3 and 4 for your NAEPP guidelines. A lot of what I use it for are the last two: poorly adherent patients. They forget to take it, or they think they're doing well, so they don't want to. Why take an inhaler if I'm feeling good? But then something catches up with them. They get a cold. They're out in the ozone this summer, or they're exercising, say early morning in January, February, when it drops to the high 20s here, and then they get cold-induced bronchospasm running their quarter marathons and running their 7 miles or what have you. And then if you have someone with exercise-induced bronchospasm or exercise-induced asthma who's relatively asymptomatic outside of exercise, these would be good candidates for smart therapy as well. So the GINA guidelines are more international guidelines. They have a group of international based physicians that that work on guidelines. They were established a little over 20 years ago, and they use worldwide based evidence based practices for their recommendations. GINA guidelines are updated yearly, and as opposed to a six-step approach, there's a five-step approach, and it doesn't distinguish between intermittent asthma and mild persistent asthma. Asthma is always considered a chronic disease in regards to GINA guidelines. The GINA guidelines did expand recommendations for long-acting muscarinic antagonists, especially tiotropium, which is usually used for patients greater than 18 years of age, but it does have a place in some of my more severe kids, and sometimes I've used tiotropium in lieu of starting a biologic if I thought the biologic would be too much a hassle for that patient. It does include smart therapy in their guidelines for children's ages through 11. And the focus with the GINA guidelines are into asthma control. They want symptom control, but they also want to minimize risk as well for adverse outcomes. That could be hospitalization, but it can also be long-term effects from chronic steroid usage, airway remodeling, and all those other issues as well. So, how do we diagnose childhood asthma? What do we do to say they're in your clinic and they come in, you have a patient that comes in with chronic cough, chronic recurrent wheezing, recurrent hospitalizations for asthma attacks, and remember the old adage, all that wheezes is not necessarily asthma. So how do you distinguish some of these patients who cough and wheeze, but they may have other things outside of asthma? So look for assessment of symptoms. You got to look when you're taking a history, look for wheezing, dyspnea, chest tightness, and cough, and see what the onset is, see kind of what the relationships are with the ongoing symptoms. And I like to do pulmonary function testing, and usually what we do is we get a baseline PFT. The main things I look at is forced vital capacity to tell you if there's a person that has a restrictive component to their airways disease. FEV1 is the amount of air that you blow out in 1 second. So usually if your percent predicted is less than 80%, it tends to indicate that there is a airflow limitation. And then your FEF 2575 tells you how quickly or the velocity at which you can empty out air from your lungs, or it's an indirect measure of small airways obstruction. So we kind of look at those measurements, and I didn't put that in here, but your FEV1 to FVC ratio, if it's less than 80%, that usually indicates that there's some small airways obstruction. So what we do is we have that patient in there, they get a baseline PFT, and even if they're on the normal end, a lot of times we'll give them a bronchodilator, and especially if they're symptomatic with, you did your assessment of symptoms and they're having wheezing, they're having chest tightness, they're having cough, all these other things. So what we do is we give a bronchodilator, and then we repeat the pulmonary function. And if you have increase in your FEV1 by 12% or more, that's considered a positive bronchodilator response. Say you have this patient in your clinic, you got a baseline PFT, you did a bronchodilator, you did not see a significant improvement in the FEV1 or the FEF 2575. Sometimes you'll see greater increases in your FEF 2575 when compared to your FEV1 in those with asthma, cystic fibrosis, etc. So say you didn't see that, but you're highly suspecting asthma. You've done one or more history and physicals on this patient, and you're you did not see a bronchodilator response, but say you're still convinced that this patient has asthma. Say you put them on a controlled therapy. Well, what's the next thing you could do to diagnose asthma? Because you're having some ongoing control issues. So what we'll do is we'll do a bronchial provocation test, and that could be one of several bronchial provocation tests. If you have a child that's having, or an adult even, if you have a patient that's having more problems with exercise, they run and they often need a bronchodilator for rescue when they're running, then I do an exercise challenge test that can easily be done in an outpatient setting, even in your clinic, if you have the right equipment and monitoring. And then if you see a drop in your FEV1 by 12% or more, that could be diagnostic as well. And sometimes what I'll do in my criteria is if I see a drop in the FEF 2575 by 20% or more, I usually consider that diagnostic for at least exercise-induced bronchospasm. What are some other things you can do for a bronchial provocation test? You could do a cold air challenge. Uh, Sometimes here in Arizona, it's kind of hard setting up cold air challenge, but basically, one of the non-immunologic um, quote unquote irritants to the airway is airway cooling. So once you cool off that airway and you have asthma, cooling off of the airway can result in bronchospasm. For those where you really need to get a good diagnosis, or say you have a person that is trying to get into the military, and they talked to their Marine recruiter that they were prescribed an albuterol 10 years ago, and the medical doctor for the military wants definitive testing for asthma. Then your gold standard for the testing is really a methacholine challenge, where you give subsequent dosing of methacholine, and once you reach your higher doses of methacholine and they haven't had bronchospasm, then it's usually safe to say that that patient does not have asthma. Uh, but um, but if you do have asthma, even with low doses of methacholine, you can induce bronchospasm quite easily. Um, so I think the combination of pulmonary function testing, looking at bronchodilator response, and bronchial provocation testing should give you a really good tool for whether or not someone has reversible airways obstruction, i.e. asthma. Of course, there's also other causes of non-reversible airways obstruction, but that could be a whole new lecture or a whole new grand rounds. So if you want to hold me to it, that's totally cool as well. But remember, a large percent of patients with asthma have an allergic component. So I feel allergy testing is a really good tool to have on board. If you have the ability to use exhaled nitric oxide, which is usually elevated in those with type 2 mediated disease or allergic disease, that can be helpful not only in your diagnosis, but also monitoring of your patients. So say you get an exhaled nitric oxide on initial visit and it's somewhat elevated, but you start a really good therapeutic regimen with this patient, their symptoms improve, or say their symptoms don't improve, but you're still suspecting that, hey, they have asthma, maybe there's a compliance issue or a compliance component, you could get exhaled nitric oxide. If you haven't seen it drop, and they're still symptomatic, there's a good chance that there's a compliance issue, or the controller molecules not getting to the airway, and so you may have to address technique issues, compliance issues, uh, Are they even able to get their medications from the pharmacy? Maybe they can't afford their medications. They're just telling you they're filling it. So exhaled nitric oxide can actually be a fairly good diagnostic tool, but even a really good monitoring tool for you. So if you do have the ability to do this in your practice, it would likely be quite helpful for you. So how do we manage our kids with the asthma? And remember, even in both guidelines, there's long-term goals, and you want to get symptom control for your asthma, but you also want to minimize your risk of mortality, morbidity. That includes asthma exacerbations resulting in urgent care, emergency room visits, even hospitalizations. Those who have long-standing asthma symptoms can get persistent airflow limitation. And obviously, when you go to even higher doses of your medications, there are potential side effects involved. And when you look at the NIH guidelines, it's recommended, or what's allowed is one steroid course per year, but how many asthma patients do we have in our practices where they've been on several courses of oral steroids per year, which tells you that the asthma is poorly controlled for whatever reason. They could be taking their medications quite frequently, but again, they're still poorly controlled. So that kind of is an impetus to start your detective work. Effective asthma management requires really a good partnership between us and the patient, make sure that they feel safe in telling you that, hey, I'm not taking my asthma medications every day, or that combination budesonide formoterol that you prescribed for me, I have to pay $300 out of pocket. And to be honest with you, I can't take this every day because it's too, it's either groceries or my combination therapy. And especially me, I like to eat my groceries. Um, so that's that. Asthma treatment is a continuous cycle of assessment and treatment. I like to bring these patients back every 3 months, look at PFTs, review how well controlled they are. Are they needing courses of oral corticosteroids? Are they needing more frequent bronchodilator therapy? Because that can actually give you insight as far as future risk for exacerbations, hospitalizations, etc. Remember that the steps to the guidelines, whether they're NAEPP guidelines or GINA guidelines, these are preferred for population-based decisions and which will work best for most of your patients. However, when that patient is sitting in front of you, right across in their chair, and they're looking at you, individual patient decision making has to occur between both of you because there could be difference in asthma phenotypes, as we talked about, practical issues. What are techniques? What's the adherence? Are we able to get the medications we need to control your to control your asthma? And that could be cost based or just access to your pharmacy and the availability of the medications. So when you look at asthma medications, the basic classes are quick reliever medications. The most common one here, at least here in the United States, is albuterol. Your controller medications could be inhaled corticosteroids or a combination therapy, inhaled corticosteroids with long-acting bronchodilator, or even adding a long-acting muscarinic antagonist, adding a leukotriene antagonist. Tiotropium is what's available here in the United States. Usually, I will start a biologic in step 5 or step 6. Inhaled corticosteroids, there's several on the market. There's fluticasone. GlaxoSmithKline manufactured Flovent for years. Last year, they discontinued manufacturing. So we have the generic fluticasone either as HFA in the inhaler, or we have the propionate dry powder version or Nuity. With my younger kids, even though it might be approved, down for the younger kids, you really got to look at technique for these kids, because I have some 4-year-olds that can do a fantastic technique with a dry powder inhaler. I have teenagers that are horrible at taking dry powder inhalers, and they start getting side effects, pharyngitis. They get vocal cord and laryngeal irritation, voice hoarseness, etc. Budesonide mometasone, beclomethasone. Obviously, you have your combination therapy with the fluticasone and salmeterol, otherwise in the past known as Advair. You have budesonide formoterol, which can be available as a generic, or Brana, or Symbicort. You have mometasone and formoterol, which is usually available as your Dulera. You have the new combination of albuterol and budesonide, which is usually can be used for your smart therapy. So you can use that as both a controller and as a rescue medications. And then you have the dry powder version, which is taken every 24 hours. Your fluticasone and vilanterol, which is also a dry powder inhaler formulation. Leukotriene antagonist, the most common one that's used is montelukast. Zafirlukast is usually given twice a day. Xylitine does have some hepatic side effects. So you have to do liver function monitoring. I rarely use the leukotriene modifiers that are needed more than once a day. Just to kind of give you an idea what the inhalers look like. Again, this is kind of an older slide, but you have your rescue inhalers. And notice that a lot of these come in different types of varieties and colors. And so, back in the old days, I used to ask, so what color is your inhaler? And I'd be able to deduce what inhaler they're using. But your rescue inhaler can come in various colors, shapes, and sizes that it's no longer a help. But for your controller medications, now again, these are some older slides, but your fluticasone, your combination budesonide, formoterol, i.e. your Symbicort, looks a certain way and has a dose counter on top. So oftentimes I will ask questions to the family and if I can't figure out, oftentimes I have them take a picture and bring a picture with them, or actually have them bring a bag of their medication so I can figure out what they're using. And oftentimes once they see that inhaler, they're oftentimes able to tell me how often they're taking it. Are they taking it with the spacer? Are they not taking it with the spacer? What's the technique? And are they doing it daily, PRN, et cetera? So they can give me a better assessment as to whether or not that molecule is hitting those receptors in the small airway or not. And if not, then we can work on that face to face. So when you're using a spacer, usually I'll have diagrams to help show the patient's family. If they're old enough to use a mouthpiece, that does help with the delivery of the medication. Obviously, for younger kids, you have to use it with a mask, and we'll go over that. But usually, if you use a spacer with a mouthpiece, I prefer a single breath hold with that, and I'll instruct my patients how to do that with a single breath hold because I feel that's helpful. It does get your better delivery, and a lot of patients will tell me that, well, we used to use a spacer, but we quit using a spacer. But then oftentimes I'll ask them, well, when you quit using a spacer, even though your child's 11, 12, 13 years old and they're old enough to do a good technique, how are their symptoms? And a lot of times, because they put the inhaler in their mouth and the particle size of the medication that's coming out of the inhaler, when it's directly puffed into the mouth, the particle size is too large, the particle speed is too high, so you have a huge amount of particles containing medicines hitting the back of the throat and the larynx. That's not where you want the molecule delivered. You want that molecule delivered in the small airway, which is where the asthma is occurring. That's why I like to use a spacer. It allows the medication to slow down. It allows the propellant to evaporate. It starts to, you start to have a higher percentage of smaller particles that can actually get delivered into the small airways rather than impact the back of the mouth so they can get swallowed, because that won't help your asthma if you're swallowing the medication. So again, I always love to use spacers with all my MDIs. With the dry powder, you have no choice. Never use a dry powder with a spacer, obviously, but I can't tell you kids I've seen that come out of the hospital who are using a dry powder with a spacer and they're getting nothing. They can't understand why they're not getting better. So in smaller kids where they are not able to do that technique where you puff the medication, inhale the medication in a slow deep breath, and then hold it for a slow count of 5 or 10, depending on how you want to do it, and then exhale, and then repeat that step for your second puff, then we can use a spacer with the mask. If they're old enough to do a single breath hold using the mask, but they're not quite well coordinated enough to use a mouthpiece, fine. We'll do it with the mask until they get the hang of it, and then they can transition to a mouthpiece. But if they're not able to do that, say they're 2, 3, 4 years old and are not able to coordinate that single breath hold, then we'll do an infant technique where you puff the medication, they breathe it in and out 4, 5, 6, 7 times, however many you want them to breathe in and out. So at least they're getting some molecule deposition into small airways. But again, the efficiency is not as good as using a single breath hold. So if they're capable enough of doing a single breath hold, even with the mask rather than a mouthpiece, try to institute that. It'll help your small airways delivery at least improve to a good degree. Biologics. So those are the newer classes of medications, and I think they definitely have their place in asthma care. The one that's been around the longest is your omalizumab or Xolair, and it's given subcutaneously. It's an anti-IgE antibody, and usually your screening testing is looking at your IgE levels and then calculating dosage out from that. So it's based on your IgE and your weight. So I've had success using Xolair. I've had a lot of patients on Xolair over the years. Um, I haven't seen too many side effects with it. And there is an anaphylaxis warning with Xolair as well as all the other biologics. But to be frank with you, I haven't seen too many anaphylactic side effects. My allergy colleagues might see more than I do. Your next ones are your anti-IL-5 antibodies. Those are your mepolizumab or Nucala or benralizumab, which is your Fasenra, and they're given subcutaneously. They work slightly differently, but they work on the anti-IL-5 um, portion of the inflammatory cascade. What's commonly being used more is your dupilumab, which is your Dupixent, which works against IL-4 and IL-13. So it binds to the IL-4 alpha subunit and IL-13, and so it tends to inactivate your type 2 immune system cytokines. So type 2 immune system are your Th2 cytokines, are your allergic cytokines. They're also involved in parasite infections, etc. They activate your IgE and your eosinophils. And so your type 2 immune response is more prominent in asthma, allergic rhinitis, atopic dermatitis, as well as eosinophilic esophagitis. So when you look at the Dupixent, there are indications using Dupixent for asthma, allergic rhinitis, atopic dermatitis, eczema, and even newer indications for eosinophilic esophagitis. So I think this helps our GI colleagues and our allergists quite nicely. Um, I'll touch on Tezspire, which is a new medication that's out. It's not approved for kids under 18, at least right now. I put in uh, some mechanism of actions to Tezspire, but even then it's fairly complicated. And since it's not approved for kids, I'm not really going to belabor the point too much, but it's a antibody against anti-thymic stromal lymphoprotein and TSLP. TSLP works early on in the immune chain, and it's activated by a host of factors that we'll touch on. But TSLP is an alarm and it occurs early on in the chain of activating most of your other cytokines down in the immune chain for your Th2 cytokines and your Th2 immune responses. See how I'm doing on time? Okay, good. So I put up this. There's going to be no pop quizzes on this, but again, it kind of works early on in the chain to work against environmental stimulators, injury to the airway, viruses. Your RSV, influenza, rhinoviruses. Your rhinoviruses are especially implicated in persistent wheezing in your kids. Bacterial infections, parasite infections, activating your not only your Th2 cytokines, but also your pro-inflammatory cytokines that are involved in airway remodeling, such as your tumor necrosis factor, your interleukin 1 beta. Again, activation of proteases, which are also involved in airway injury and chronic remodeling. So TSLP tends to activate different cell lines, including the basophil, mast cells, fibroblasts, and then down the chain, it will activate T cells and B cells. It'll recruit your eosinophils. It'll activate some of your natural killer T cells and smooth muscle cells as well. So when you're looking at inflammatory cascades, it's definitely a player. And so hopefully this new medication that Tespire will make a difference. We'll see if it gets approved for our teenagers as time goes on. So how do you manage acute asthma? I'll go through this rapidly because a lot of y'all do inpatient care, and some of the IC docs can do this way better than I can. But remember, the goal is to rapidly reverse small airways obstruction and prevent acute disease prevention. Supportive care, IV fluids, oxygen, IV or PO corticosteroids. If in the hospital settings, we use IV steroids, obviously. Beta agonists, sometimes we'll use IV beta agonists, terbutaline, those things. I don't use theophylline as much. Maybe there are some places around the country that do, but I don't like theophylline just because of its narrow therapeutic index. Anticholinergic therapy, that's your Atrovent of the world, supplemental oxygen. Oftentimes, our kids in the ER will receive a course of IV magnesium, methylxanthines, your theophylline. And those who are going into ICU, we can use Heliox mixtures, either at a 70-30 mixture or a 60-40 mixture. And remember what the helium oxygen does, it makes the air more streamlined so it could get through those areas of obstruction and deliver oxygen to the more distal airways by streamlining the flow of oxygen. Obviously, if you're not doing well, we tend to resort more towards non-invasive ventilation, BiPAP, high flow, oxygen, vapotherm, etc. Your last resort's invasive ventilation. But say you have a kid that has to go on to invasive ventilation or higher pressures of non-invasive ventilation. You got to use sedation for these kids because oftentimes they're going to fight the ventilator on you. Obviously, indications for invasive ventilation are you can't improve their oxygen saturations even at on 100% oxygen, respiratory fatigue, respiratory failure, your severe obdentation, you're having loss of consciousness because of CO2 retention, and acute cardiopulmonary arrest. But say you do have to use mechanical ventilation on your kids. What are some options for sedation you can use? Ketamine can be an option for you. Obviously, we don't only use one agent for sedation. We use many agents for sedation, but one that you might want to at least consider in the ICU setting. But obviously, it depends on the situation and patient involved, as to whether there's other mitigating factors. But ketamine is an analgesic and anesthetic, and it does have some bronchodilator properties. But if you have seizures, it'll lower your seizure threshold, and you can get hypertension and tachycardia with that. I've seen increased tracheal secretions that can form mucus plugs in the endotracheal tube with your ketamine. And then if you have any liver disease, or say you have some liver dysfunction due to acute hypoxemia, that might not be your best option to use. So avoid in patients with hypertension, preeclampsia, increased intracranial pressures, epilepsy and liver dysfunction. Propofol can work as well. Rapid onset of action. You can titrate propofol up and down, and so you can achieve deeper levels of sedation or lighter levels of sedation fairly easily if you're ready to extubate. It does work well with your paralytics as well. It does have some mild bronchodilator effects, but it does decrease your respiratory drive in case you're trying to have these patients support themselves. So you can get some CO2 retention. Oftentimes, when you have to put one of your asthma patients on mechanical ventilation, ventilator asynchrony is a big issue. So a lot of times, at least early on, we have to use some neuromuscular blockade. But that obviously that can lead to muscular weakness, myopathy, in combination with steroids, which accelerates the myopathy and muscle weakness. So the best thing to do is try to get in early, try to get these kids taken care of early so you do not have to proceed with mechanical ventilation, because it just opens up a huge can of worms for our patients. And obviously, it increases the morbidity, increases your chance of mortality, results in a way longer hospital stay. So, well, that's all I have for this lecture. I want to hear what you have to say, and if there's any questions, please feel free to ask. Somebody's got to have
Thanks,
a
Kel.
question.
Sorry, go ahead.
Somebody's got to have a question.
Kelvin, one of the things we've struggled with the new guidelines is actually from an inpatient side is coming up with an asthma action plan
Yeah,
that
yeah.
actually makes sense, because it used to be a lot easier, and now there's a lot of sort of convolutions based on age, and it's a little bit harder to sort of easily get patients to understand what you want them to do with a few words. Do you have any advice on that, or do you have any sources or resources about?
So oftentimes when I have a patient coming up with an asthma action plan coming out of the hospital, usually when we have the asthma action plan approach from the hospital standpoint, it's more based on acute care. So oftentimes it will have to be revised as an outpatient once we're able to establish a few things. What's the control of their asthma? What's their compliance? Are they able to get the medications? Are they going to be able to keep their follow-ups? And then once they're in the outpatient side of things, it gives me a much better understanding of how well controlled they can be. But your job as a clinician in the hospital setting is to get that kid better as much as you can. I think establishing an asthma action plan is actually a really, really good idea. But remember, you're coming at it from a standpoint of acute care, and the asthma action plan is chronic care. And what do you do about those acute exacerbations, getting to those acute exacerbations early so they don't have to come back to the hospital? So oftentimes those plans do have to be modified or are revised to reflect the chronicity of the outpatient care. But I think the inpatient setting, they got to that inpatient setting for a reason. So I think even coming up with an asthma action plan that works at that time, knowing that it's going to have to be changed at some point in the future, that's totally fine. That's totally
Okay.
acceptable to me.
Okay. Great. Then I'll keep it simple. Thank
Thanks.
you. No, I appreciate that. It makes my day easier.
Good. I want it to be easy.
Any other questions for Dr. Panesar? If there are not, just want to remind people to go over to the chat real quick. There are a couple of links over there for CME certification, as well as our SurveyMonkey link. If you could take 12 seconds to answer the 5 questions, that helps us a lot. And again, the CME tracker code and everything's in the chat as well from Megan. Dr. Panesar, I want to thank you very much for taking your time this morning
Oh my gosh,
to go
thank you.
through the asthma guidelines with us. So thank you.
Thank you so much. I appreciate it.
All right.
Yeah, thank you so much.
Thank you.
Thanks, everybody. Appreciate it.
Thank you.